Aortic arch replacement, 5 circles. Bentall operation, 4 circles. So all we've got to do is stitch 4 circles. So probably one of our record routes, 40 kilo lady, 14 centimetre root. But as Roberto and I were talking about at breakfast, the bigger the aneurysm, the bigger the miracle. So I thought about sort of final year resident, junior specialist, come in to do your Bentall, maybe first time on your own, first one with the boss helping you. What are the sort of inhibitors that worry you the night before the operation? So firstly, dissecting out the root, then we've got a size, we put the conduit in, and obviously coronary reimplantation. So this is that lady, that's a big one. I'm not going to talk a lot about cannulation. We often go peripheral so that we've got a lot of room at the top. We put the clamp on. I like to transect it completely. I like to look down on it as a circle and then dissect beyond the coronaries and down to the root. Not as far as you'd go for the reimplantations, but you do want to give yourself a reasonable room. So dissecting off the pulmonary artery, this can be a bit of a challenge. I did have a slide, I took it out last night with multiple buttresses on the pulmonary artery just to show that we're human, the same as everybody else. But when it's big and inflammatory and stuck, this is the area, and this is where you just sort of take a little bit of time, but you do want to free it up completely from there. We try to leave a good rim of aortic tissue, okay? Maybe 4 or 5 millimeters at least. And the reason is that in the non-coronary commissure, particularly, the annulus can be stretched and be very thin, and we can use this as supporting tissue when we put the conduit in, okay? The one thing in all of your minds when you're doing this operation, I know, is bleeding. So everything we do is to ensure hemostasis, really. So you need a little bit of a backup plan to how you're going to reconstruct it all. So again, leaving a little bit of a remnant of the aortic wall, coronary mobilization, big buttons. You can see that we leave a huge margin at the top. We can trim that at the end of the procedure, but we can put stay stitches and take the coronaries right out of our way when we're concentrating on putting in the actual conduit itself. We do intraannular placement, so 3 stitches, each in the commissures first. That pulls the annulus up towards you so that you've got a good view. The coronaries are well out of the way. So now it becomes a very straightforward reconstruction, 4 circles. This is mobilizing the coronaries. Know your coronary anatomy. That's very important. But actually, there shouldn't be much controversy in a first-time operation. This isn't a very good picture, I'm afraid, but this is going around the back of the right coronary. And you don't actually have to cut. You can just slip your scissors around, and it'll take the lower edge of the coronary off for you. And then when you want to dissect it a little bit more, you can see that there's very fine strands here between the coronary and the outflow tract, and it's very easy then to mobilize up. You don't try and mobilize it completely when you're doing this, because you can leave that to see how much you need when you've got your conduit in. Sizing. The last thing you want is to oversize so that you can't fit the conduit in, right? We usually do intraannular placement just because I think that's more hemostatic for first time sort of Bentall operations. And when we size it, what we try and do is leave what we call the triangle of safety. So remember that the sizer reflects the prosthetic that's going to go into the annulus, yeah? You've still got to judge for the sewing ring. So if we can pull on one commissure and see a little triangle, we know that that conduit's going to go in nicely and it's going to be hemostatic. So we put buttress stitches, it's intraannular placement. We put them directly into the conduit. The only reason that we do that is because I can't count. So if we put them all in first and you've got all of these sutures and it's how many have we used, how many have we got here, that my brain doesn't work like that. So I just put them straight in the conduit. We always use, we can talk to the guys here, we use a valsalva graft. It's the same sort of graft for the reimplantation. There's obviously advantages in that situation. But for us, we like these sinuses because they bring the conduit nearer to the coronary arteries. So there's less of a worry about mobilizing up the coronary arteries. So this is the graft in place, and this is what you want to see. You want to see aortic tissue between your buttress and the conduit. And looking at that, as the audience, I'm sure you can look at that and say, there is no way that's going to bleed. Okay? You can be absolutely sure that's not going to bleed. We glue. You can use any glue you want. I've got no idea how they work. We use this one just because it's easy. I can press a button and stuff comes out and it's sticky and it seems to be okay. And then the coronary reimplantation. Again, we're very simple. It's 2 circles. So we just do a direct, usually 5/0 anastomosis with these. There's lots of little tricks if you're struggling, which maybe we can talk about in the discussion, but it should be relatively simple. And when you've implanted the coronaries, you can inject cardioplegia into the graft and you can check them for hemostasis before you glue. Okay, so you can be absolutely sure that you've got dry coronary anastomoses. We all like to have a little bit of a parachute, a little bit of a backup plan. It's very unusual that we need to do this for a first-time Bentall, but if you've got it in your armamentarium, it can keep you out of trouble. So this is a modified cabral, particularly useful in redo situations. So we've basically got an 8mm graft attached to the left coronary there. And again, what we're doing here for hemostasis is we're injecting down the conduit to make sure that it's absolutely hemostatic. So this can be quite useful. We don't do it like they do in the books. You can see that here, the right-sided cabral is just an extension graft. So we don't bring the 2 loops around because I think that fixes it and it's difficult for hemostasis, but we bring the left round onto the side of the valsalva graft. And this is just a CT scan of that patient. And what you can see here is you can see the left-sided cabral filling quite nicely at a nice angle. And that should be your end result. Okay? So that's 6.5 minutes on the Bentall operation. It's 4 circles. You can make it completely hemostatic. Some of the keys, I think, are the dissection. Transect the aorta high, but give yourself enough room to do the distal anastomosis. But then you've got a good view of the anatomy looking down. A little bit of head up of the patient sometimes helps. Just tilts the root so that you can see it. Dissect beyond the annulus, but not too far, and leave an aortic cuff, particularly in the non-coronary commissure. That can keep you out of a lot of trouble. Size with the triangle of safety. We put it intraannular, unless it's a reoperative situation, which we'll talk about later. And then we often put that supraannular because we've got a patch or buttress stitches, maybe even on outflow tract because we're quite down, quite deep. Visible aortic remnant between the sutures and the conduit, and then you know it can't bleed. And we always, when we tie the conduit down, even though we're not worrying like an aortic valve about getting it below the coronary arteries, we always tie the non-commissure last. If you've made a slight misjudgment of conduit size and it won't go down, you can fix that commissure, but it's very difficult to fix the left or the right. Coronary implantation, know your coronary anatomy, use the valsalva graft, that makes it a little bit easier. Test the anastomosis, so again, you're sure of your hemostasis before you complete the operation, and have a backup plan, know how to do a modified cabral to keep you out of trouble. Okay, that's your 4-circle Bentall operation done. Thank you.
Malcolm, I'm just adding something on your leaving a little bit of the aortic wall. I also leave the valve.
Yeah.
I don't resect the valve. I can't see the point of doing this. I just use it as a buttress for my suture line.
Yeah,
so,
perfect. Yeah, absolutely. But you know what it's like when you get a proper big one, and you come to put stitches, particularly in the non-coronary commissure, it's like stitching through air.
That's right.
If you just leave it as the annulus. So sure, if you want to leave the valve, fine, or we just do a sort of little double wrap of the aorta, and then you make sure
just
it's absolutely
any tips and tricks for avoiding right coronary issues?
In terms of, I mean, dissect it right, dissect it the right length.
So in my mind, the Achilles of a Bentall is getting right coronary ischemia,
Right.
which is doubly dangerous because it doesn't always show up at the end of the procedure.
Okay.
You can leave the operating room thinking everything's good and then get being in ICU, and then it's back onto ECMO and so on. So for me, when I teach, it's all about the right coronary.
Oh, now you're frightening me.
So you hear different people saying different things. You've got to hitch it up as high as you can, etc., etc. What's your foolproof?
So, George, I don't recognise that bad scenario, and that's why you've worried me, because maybe that will happen to me now, but I haven't recognised that. I think we worry less about the right coronary than the left coronary. I think that we don't dissect it very aggressively to start off with. We wait until the conduit's down, and then we can inject in the conduit, see where the sinuses are going, and then just dissect it enough. And over the years, I've moved to doing really big coronary buttons. Bigger than I started off with. In those slides, they're probably quite small, but now I do them quite big, and then you're not going to compromise it at all. You've got to be careful not to dissect it too long, because then I think it can kink, and that would be one of the issues. So I wouldn't get too paranoid about it, though.
So we both reached the same conclusion. I get criticized of having a big coronary button, but I think it's the safest thing you can do.
I totally agree.
And from doing redos afterwards, if you started with the big buttons, you've got something to dissect for your second operation.
Yeah, that's probably
Which
true.
is really very important for your second operation.
That is true. And the other thing we do sometimes, not in an elective Bentall, because you've never really got the problem of the left coronary, but let's say in a type A dissection when you've got to do the Bentall. And that's a real worry. So I had this conversation with David before. I don't know if you guys watch Australian MasterChef. I'm obsessed. It's fantastic. I tried the New Zealand one. It wasn't as good. I'm sorry. But they have this thing called, in every recipe, there's a pressure point. Okay? So let's say you're making a souffle, a vanilla souffle. If you get the vanilla a little bit wrong, it mightn't matter, because some people like more, some people like less. But if you don't get it to rise, you're finished. So that's your pressure point. So if you think about a Bentall in a type A dissection, what's the pressure point? What are you all worried about? You're worried about the left coronary, aren't you? You're worried because it's dissected, it can be difficult to reconstitute, and you're worried because if it bleeds, it's very difficult to get back. So what we do sometimes with that is leave a really big button, put a strip of pericardium between the two layers, and stitch it together. And what we'll sometimes do is make a big hole in the conduit and put the coronary button on the inside, and then use in and out mattress stitches so that when the conduit fills with blood, it presses this big coronary button against the graft and it'll stop it bleeding. So this is a simple 4-circle operation, but now we're seeing that as you start to get into areas of controversy, there's lots of little tricks that you can have in your armamentarium to put it together and stop the bleeding.